Welcome to the basic hip session. So for next 8 to 10 minutes, we would be focusing on templating the basic hip. All right. So my job is to start with the basic and then finish with the modern techniques. We have to be fast because it's a very vast topic. And in recent few years, many good things, many new templating methodologies, they have come up. So point number one is that it's a subjective thing. Even with the computer or AI, subjectivity cannot be completely removed. And things like springiness of the bone, it cannot be predetermined by templating. So intra-op evaluation is the best thing. Now having said that, templating is a good thing because it improves your understanding of the surgery. It improves the understanding of total hip replacement as a whole. So to start with, वो मिलेगा क्या pointer? To start with, it's good to write whether there is osteoporosis, whether there is sclerosis. It's good to write the diagnosis, followed by marking the teardrops, then marking the acetabulum, then these three lines, the interteardrop line, the other two lines, then the measurement of the limb length discrepancy from the upper part of the lesser trochanter. Then you measure the sorsal angle to make a diagnosis. Then you get a 45 degrees angle from the interteardrop line. And then comes the most important part, how to put this template. Now point is that you have to be in close relationship with the teardrop. You have to be in close relationship with the superolateral edge. And then you decide your size based on one notion that do not remove too much of bone. This is how you make a templating of the acetabulum, and then you mark the center of the rotation of the acetabulum. The next line is to make a line parallel to the interteardrop line crossing towards the center of the acetabulum. Now as there is no limb length discrepancy in this case, so we will keep the femur center of rotation also in the same line. This is how you template the femur. You look at the medial metadiaphyseal part mainly. So it's easy. So what's the problem? So the problem is this, the magnification. It's more in obese, less in thin. So to get the magnification issue sorted out, we have digital templating in hip arthroplasty. In India, we have OrthoView, we have TraumaCAD, and we have Bone Setter app. So to start with, you need a magnification marker. The best magnification marker is the other side hip. You know the dimension of the other side femur head, it's 36 mm. So this is how you measure it, and then you put 36 mm, you align the X-ray, and you get proper magnification because this is 36 mm, you know that. Then you measure your different angles. If you want this to be done automatically, then you need TraumaCAD software where there are specific markers, one on the back side, these rods, and in the front side, these spheres. You choose for the hip, you go for automatic marking, automatic magnification. The software measures these things and they decide the amount of magnification that is there. You choose from the different implants that are there. You put one implant, you can change its position, and same like acetate templating, you do for the femur. You can put offset liner, you can put 28 mm head, 36 mm, whatever you want. You can use dual mobility, and you can measure different type of parameters, and finally you attach the stamp to the cup and you save it. So this is how TraumaCAD is done. So the whole point of digital templating is based on this thing, the magnification marker. So there are many different magnification markers available. One is the Voyant mark by TraumaCAD Brain Lab. So you have to put it close to the greater trochanter, or best to put it in between the thighs, but this is an awkward position for the patient as well as for the radiographer. So there is a different thing, the King marker. So King marker is for thin as well as for the obese individual. It has rods on the back side and spheres on the front, and the software automatically measure the difference between the magnification of these things and decide about the magnification. And the software also tell you about the prominence of the lesser trochanter. If it's close to 5 mm, then it indicates that this limb is in 15 degrees of internal rotation. And there are many different papers that supports the concept of this King marker. So if this is okay, then what is the problem? The problem with digital templating is the large cups. If you go beyond 56 mm, then the accuracy decreases. And another problem is that you need proper X-rays for digital templating as well as for the acetate templating. And sometimes it is not possible to get these good X-rays in the presence of gross deformity. So what you do 2D templating. So you get the cut in the line of the femur neck. In this way you get the true AP view. You increase the thickness in the DICOM software. and you measure it. You increase the thickness in the lateral view, you measure it. And then you measure the axial cut. So this is how you will decide the acetabular size. Now, if you want these things to be further fine-tuned, then you need 3D CT based templating, in which you do proper segmentation. You get a picture like this, use 3D matic materialize, and they will give you a proper pelvis picture. You can use a circle to decide the size. You can use a sphere to decide the position. You can use the stem. You can look from top to decide for the anteversion. You can take the axial cut to know the amount of bone that has been removed. You can note the superior gap that is there, and this is all done. Now, if you want to further do the automation, use the AI, then you have this Corin software. They measure everything. They measure the lumbar flexion, they measure the pelvic incidence, they measure spinopelvic issues, they measure the stem version, and they tell you about bone impingement, about soft tissue impingement. They give you different parameters. And if there is some sort of impingement, you can change the inclination and remove that impingement. You can use offset liners. You can do planning in the 2D, then replicate into 3D. You can, and another important thing is this heat map. So if the template, if the implant is touching the cortical bone, that this software shows you the heat map. So you can change the version. You can change the size and get the proper position. You can use offset liners and remove the impingement. So this is a wonderful software, it's Corin software. Furthermore, it gives you the dynamic analysis of the spinopelvic issues. It gives you a proper video. It tells you about edge loading in the ceramic cup. So, and the same thing is also done by the Mako. Now, Corin versus Mako, there are no studies. Only one thing is, and this was published, this has been published in this month's record, in September 24, that it's good to do both in cases of complex primary cases, to get it. Thank you so much.